Welcome to Chapter 3 of Essentials of Healthcare Finance, Financial Environment of Healthcare Organizations. This chapter focuses on the roles of hospitals, doctors, private and government insurance, and different systems for organizing and financing care. The chapter covers Medicare reimbursement in particular for the following healthcare sectors: hospital inpatient and outpatient, physicians, skilled nursing facilities, and home health agencies. Numerous data are provided to show the sources of revenue for the various sectors. The learning objectives for this chapter are questions to answer. What is the basic business structure of a healthcare organization, or HCO? Viability of payers and payees. How are HCOs paid? The types of payment systems. Medicare payment. Here's an illustration of a basic business structure for an HCO. The HCO in the middle, which consumes resources, so it needs to receive those supplies from a supplier. The supplier provides those services to the HCO. The HCO in turn uses those and provides services to patients, to the community, who the community is the consumer of resources at the hospital. So you can see the supplier provides services to the HCO, which provides services to the community. The community is the one consuming the resources. The HCO must reach back to the suppliers to replenish their supplies. In the long run, you cannot pay out more than you make. You may also hear this as no margin, no mission. So who's the supplier? Supplier, they have employees, they're equipment suppliers, service contractors, consumable goods suppliers, and lenders. All make up the supplier bucket. The healthcare organization, as you can imagine, would be a hospital, a nursing home, a physician group, ambulatory surgery center, or clinic. And the community, patient side, self-paid patients, and those with insurance that have maybe Blue Cross, a commercial insurance, Medicare, Medicaid, a self-insured employer plan, or some other type of third-party coverage. For the non-patients, it would be grants, contributions, tax support, and miscellaneous. So the sources of funds they come in the form of revenue and capital or in gifts. For revenue, they come from public sources such as Medicare or Medicaid on the patient side, or from a patient's private insurance, whether it be Blue Cross, a self-insured plan, a commercial insurance, or some other type, or direct payment, self-pay, or other non-operating revenue. Capital is a form of taxable debt or tax-exempt debt, depending on the type of structure, and also have access to equity or stock partnership, depending on the type of structure. The uses of funds: the revenue is typically used for expenses such as salaries, supplies, and insurance. Capital is used to cover interest, debt principal, and dividends to partners. And for investment, you need working capital for buildings and equipment or to replace reserves that may have been used. In this table, you can see sources of funds for U.S. hospitals by percentage. You see the out-of-pocket payments comprise 3.2% in 2014 and 3% in 2025. Private health insurance made up 35%, almost 36% in 2025 in this projection, and has private and government sources at about 10% in 2014, down just a little bit, it's 9.6, almost 10% in 2025. With government creeping up in terms of its percentage, in terms of source funding, 27% 2025 for Medicare and 18% for Medicaid. One observation that you may notice here is the increase in government percentage and the decrease in private. One of the interesting things to remember is that Medicare reimburses about 83 cents on the dollar, and Medicaid reimburses about 78, 79 cents on the dollar. So a hospital is not even recouping their cost So that is why it is important to monitor what percentage of your payer mix is comprised of Medicare and Medicaid. Here's a similar table for source of funds for physicians. And you can see here that the private health insurance has the largest share for the physicians at 42% in 2014, going down in 2025 as our trend continues. And Medicare makes up 25% and is projected to rise to 29%, almost 30% of a physician practice's source of funds. The primary difference between fee-for-service and capitation reimbursement is that under fee-for-service, each encounter creates additional revenue for the provider. The encounter may be defined as a visit, a diagnosis, a hospital stay, or in some other manner, but the key feature is that the more services that are performed, the greater the reimbursement amount. Under capitation, the provider is paid a fixed amount per covered life per period, usually a month, so you may hear it as per member per month, regardless of the amount of services that are provided. Under historical cost reimbursement, payers reimburse providers for all costs, a system that provides little incentive to control cost. Facilities will be lavish and amenities plush. Services that may not truly be required may be provided because more services lead to higher costs, which means higher revenue. Cost-based reimbursement is the least risky for providers because payers more or less ensure that costs will be covered, and hence profits will be earned. With charges for specific services, providers have the incentive to set high charge rates, which leads to high revenues. However, in highly competitive markets, there will be a constraint on how high providers can go. Because billed charges is a fee-for-service type of reimbursement, in which more services result in higher revenue, a strong incentive exists to provide the highest possible amount of services. In essence, providers can increase utilization and hence revenue by creating more visits, ordering more tests, and extending inpatient stay. Although charge-based reimbursement does encourage providers to contain costs, the incentive is weak because charges can be more easily increased than costs can be reduced. Providers bear the cost of service risk in that costs can exceed revenue. However, if providers set charge rates for each type of service provided, they can most easily ensure that revenues exceed cost. For hospitals, the list price can be found in a hospital's charge description master or charge master. And when a patient receives services, all of those services are logged onto that patient's bill. These claims would contain all of the items from the charge master and can be very long. Hospitals use a standard billing format that are developed by CMS that we spoke about before, called the UB92, and now it's called the UB04 actually. The UB04 is more condensed than a complete claim because all of the items from the charge master are typically rolled up to a higher level, usually by a revenue code on the inpatient side. These revenue codes coincide with functional areas within the organization. The physician billing format is the CMS 1500. And the payers who pay this arrangement fall into three groups: patients without insurance, patients with insurance from a firm that does not have a contract with that healthcare organization, or insurance firms that negotiate a discount of charge contract with the healthcare organization. A capitated rate is simply a negotiated arrangement between a payer and a provider to cover specific services for a defined population over an established period of time. An example would be for an insurance company to contract with OSU Medical Center to cover all hospital care for its beneficiaries for a given year. The insurance company would pay OSU a fixed amount of money per month, knowing that the hospital service utilization could fluctuate each month. Capitated arrangements gained popularity in the mid-1990s, but have been declining in favor of ACOs, accountable care organizations. ACOs represent groups of providers that come together to give coordinated patient care so that the payer has more control over the global cost of care for an enrolled population. Bundled services have two key features. Their payments to the provider are not necessarily tied to the services provided to the patient that are recorded on the UB04 or the CMS 1500. These arrangements have a fixed fee specified per unit of service. How healthcare organizations are paid, some examples of that: for a hospital, they're paid based on Medicare DRGs, which are diagnosis-related groups, or APCs, ambulatory payment codes. Per diem, a per diem rate or per day rate or a case rate. Physicians may be their reimbursement may be based on resource-based relative value scale or RBRVSs. You may also hear these referred to as RVUs. Or skilled nursing facilities, they may be reimbursed according to resource utilization groups or RUGs, and home health agencies may be reimbursed based on home health resource groups. Bundled services for Medicare. Medicare primarily pays hospitals on a bundled service arrangement. This is referred to as the Prospective Payment System, or PPS, which was officially launched in 1983. Some facilities are exempt from PPS, including psychiatric hospitals, rehab hospitals, children's hospitals, long-term care hospitals, distinct psych and rehab units, hospitals outside the 50 states, hospitals in states with an approved waiver, critical access hospitals, and comprehensive cancer clinics. Medicare has 3 insurance plans for beneficiaries. Part A, which is hospital inpatient coverage, skilled nursing facilities, hospice, home health, and inpatient blood coverage. It's typically for all persons older than 65 years and some other groups. Part B is optional coverage, and it provides coverage for physician services, hospital outpatient services, labs, durable medical equipment, and other coverage. Again, all persons older than 65 years who choose to pay a monthly premium will have access to Part B. Part D is relatively new, and it is the prescription drug coverage. So all persons older than 65 years who choose to join it can have Part D. Physicians either participate or do not participate with Medicare. If they do participate, then they agree to accept Medicare's assigned fees for services and agree to only charge the patient for the copayment, which is usually 20%. They, as participating physicians, will be included in a directory of participants, and they will have access to electronic claim transmission. When they're participating, they will receive payment at 100% of the prevailing charge on their fee schedule, on the Medicare's fee schedule, versus 95%, which gets paid to non-participating physicians.